helping individuals, families, communities achieve, as I said, optimal levels of health status, improve patient family compliance with therapeutic healthcare plan, empower patients and their families to participate in care processes and decision making, improve patient and family health team relationships, disseminate concept sound health knowledge in the community, enable people identify their health problems and needs, help people in solving their health problems, build normal health trends. By taking a fast glance at the goals of patient education, we can see there are a lot of strong words, including empower, improve, enable, help, problem solving. As we can see, the main focus of patient education is to empower the individuals, empower the patients to achieve optimal health status. It's not our job to tell them to do one by one. We want the learning process to be interactive. We want the learning process to be voluntary. And that is why we, as health educators, as healthcare professionals, we must focus on helping them, empowering them to make the right decisions, even when we are not around, even when health services are not nearby. It's the basic of health education services. As you can see, patient education concept, this diagram shows you the many different concepts that are within the patient education: health promotion, leadership, technology informatics, healthcare quality, collaboration, communication, adherence, motivation, development, culture, family dynamics. When we talk about patient education, to the layman, they might think patient education is a simple concept. But when you come to the practice, when you come to the concept, you see that within patient education, you are affecting many different concepts, many different sides of the life of the individual, of the life of the community, including all these different concepts. And thereby, we have to put our energy, put our focus 100% if possible on each level so we can achieve the goals that we said before. Health behavior theories. Why do we include health behavior theories? For us, healthcare professionals, we use these health behavior theories throughout our practice on a day-to-day basis. Why? They serve as a guideline for our programs that we try to implement, organize for achieving the goals that we have agreed upon. What are the benefits of health behavior theories? Models of behavior change have been developed to guide strategies to promote healthy behaviors, facilitate effective adaptation to and coping with illness. These theories, regarding of the specific theory, each one what the name of the theory is, they all focus on three main factors. Factor number one, factors influencing behavior determinants, including facts within the individual, such as thoughts, feelings, belief. These are all related to the individual, to that 1% that we are trying to implement that program. The second factor, factors in groups or relationships. And the third, and the most important factor when it comes to implementing programs, factors that exist in organizations and communities, such as structures, regulations, policies, and laws. This factor, in fact, has a very large effect, because once you change the regulation, once you change the law, coming of results becomes much more easy, much more facilitated to the individual, to the community, and this will help the community overall achieve the goals of optimal health. How are these theories useful? As I said, they are a guideline, but there are different uses for them also. Toolbox for moving beyond intuition to designing, evaluating health education interventions, foundations for program planning and development that is consistent with using evidence-based interventions, a roadmap for studying problems, a guide to help explain the processes for changing health behaviors and influences of the many forces that affect it, and a compass to help planners identify most suitable target audience. So we can see they are a toolbox, they are a roadmap, they are a compass. Overall, They are the guidelines for our programs, because sometimes when you try to implement based on just your effort, you might not achieve the goal. However, these theories have been developed with specific steps, taking in fact different factors that once you try to implement a program and take one of these theories into your mind and go step by step, you will hopefully not just achieve, maybe your goal was 75% of the optimal results, maybe it was 80%. Hopefully with these theories, you will achieve no less than 95 to 100% of the result, because throughout these theories, you can see where are the defects, where are the gaps that you need to focus on, make needed changes, and implement the programs. Here you can see an example of these many theories. Of course, the theories, these are examples. They are not limited to. If you want to research, there are many theories that you can benefit in your health education programs. Of course, due to time restricts, I cannot go into details with each theory. However, we will take one of them, for example. We have the rational model, the health belief model, the trans-theoretical model of change, the theory of planned behavior, social cognitive theory, communication theory, and we also have diffusion of innovation theory. Some of these theories focus on beliefs. Some of them focus on incentives, how you can incorporate, how you can encourage a positive, conducive behavior. Each one has its different rules, has its different guidelines, and with the implementation, it helps with achieving the optimal result. We will take, first of all, how do we choose which one is most appropriate? How to choose a theory to apply? We have a lot of theories, not just 5, not just 10, many theories. How do I know which one is most appropriate? I've taken into my account different factors, including the topic, target population, and I don't choose a theory just like that. I have to do a thorough assessment of the situation. Thereby, when I decide on the theory that I will apply in making the health education program, it must be logical, it must be consistent with everyday observations, it must be similar to those used in previous successful programs, and supported by past research in the same area or related ideas. Because if you read upon these theories, they are different. Each one is unique. Each one has a different personality, different traits. When we read upon them, it opens to you a different guideline to how apply education programs. But then you come to your own situation, you come to this patient, you come to this community that you want to apply change. You have to study the situation exactly, and then decide which one is most appropriate. And once you choose, you apply, and then you will achieve your hopeful results that you wanted in the beginning. Of course, these theories are a lot of words. How do we make link between the theories and the practice? This is the most important one. For this section of the lecture, we will take the health belief model as an example. The health belief model, as from the name, it focuses on the beliefs of the patient that will hopefully, if we target them with the appropriate actions, we will receive the appropriate results. Health belief model, developed by Rosenstock, explain individual decisions for health screening opportunities. The 3 primary points of this model are individuals' perception of susceptibility and severity of the disease. A belief must exist that illness can be avoided and that taking actions can reduce the risk. And finally, the individual must also believe that he/she is capable of making the necessary changes. This diagram shows you in much more details the beliefs. As you can see, in the beginning, you have the demographic variables regarding the patient, the age, gender, ethnicity, personality, and then we come to the 6 main elements. We can see from top to down: perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cues to action, self-efficacy. All together, if implemented well, it will lead to likelihood of behavior and hopefully optimal change. This is an example of the use of the health belief model for TB treatment adherence. We have a patient, TB patient. We want them to comply to the medication. Now you can see through the diagram how they apply the health belief model. For example, you see the susceptibility. The severity is the patient believing TB is a fatal disease. The benefit is that the medication will make me better. The barriers include I may experience side effects from the medication. We take all these beliefs together, then we will have belief in a personal health threat, that the patient will get over it, and belief in the effectiveness of health behavior. And hopefully all together, as we said, all 6 points together will lead to health behavior. If it gets worse, I will take the medication. Of course, when the healthcare professional takes this model, he will assess the patient, study the points, and see where the gap for the patient, and together work on the beliefs to achieve the final belief, which is taking the medication and complying to the TB treatment. And this is, of course, as an example for the application. If you want to look for it, you will find many different examples used upon this belief and the many other theories. Another point in administration of health education program is focusing on learning domains. Learning domains are the areas that you focus on when teaching, when trying to implement education programs. You have to assess the patient to know, am I teaching information? Am I teaching a skill? Or the information and the skills are there, but I have to influence the attitudes. These are called learning domains. So the learning domains refer to type of learning in which learner will be engaged. We can see cognitive is the knowledge, psychomotor is the manual motor skills, and the third one is the affective attitude, motivations, value of discipline. When trying to teach, and this is not just for health education program, this is for learning and education in general, we have to put in mind, these are called Bloom's taxonomy of knowledge. They are 3 domains. We see where the gap is and we focus on and we implement the program. These are more details about the 3 domains: cognitive, affective, and psychomotor. Psychomotor, from our field, from here in the working in the hospital, working with patients, we can see, for example, a diabetic patient applying correct techniques for aspiration, injection of insulin. This is a skill. For a skill, we focus on the psychomotor domain, the third one. If I want to just give information, knowledge, strategy, verbal information, this is the cognitive. How do I know that the patient understands from the cognitive domain? I can test them through memorization, understanding, problem solving, categorization, for example. The affective is different, because when you talk about the affective, you talk about the heart, you talk about the attitudes, the emotion. So this one might be a little more tricky, and the outcomes, they usually come by a change in the patient, in the learner's attitudes, in their emotions, in their sometimes even beliefs. We have to put in mind all of these 3 when working with the patient, because sometimes the focus might be on 3 of them. Sometimes the focus might be only on 1. So, of course, how do we decide? Through proper assessment. We finished now with the theories and the domains of learning. We will go through the code of ethics of health education. Health education, just like many other health professional care in the hospitals, in any situation, has a code of ethics that we have to go by, including respect human dignity and rights, respect of individual family independence, client consent, confidentiality, non-discrimination or stigmatization, equity in access, coverage, service delivery, respect for cultural values, refraining from conflict of interest, and integrity and good personal conduct. All of these are vital. All of these are essential in the code of ethics when working with patient education. But you can see some of them are very similar. It's about respecting the differences, respecting the need for individualization of programs. Sometimes, even if you have 2 patients, diagnosed with the same disease, the approach is different. The approach is completely, it's 180 degrees different. Why? Because each patient has a different situation. I'm not just giving medication, I'm registering, I'm informing them about their situation and giving them education. So I have to put all the differences in my mind so I can administer what is most appropriate. Because when it comes to education, it's not just 1 + 1 = 2. You have to make sure that when you do something, you want the patient to benefit. You want the effort that you put in patient education to achieve the result. So, after all this discussion, what are the responsibilities of patient educators? The responsibilities are numerous, are many. These are some of the most important ones for us all to focus on: assessing individual and community needs for health education, planning effective education programs, implementing the education programs, coordination with the provision of health education services, acting as a resource people, and also advocates. We, as healthcare professionals, as patient educators, are always advocates for health education, always advocates for the health of the individuals, health of the communities. This is a major role that it has become more and more vital these days. Also, communicating health and health education needs. And finally, one of the most important roles that we have to do whenever we have a program is evaluating the effectiveness of health education programs. Why do we evaluate? Because when you evaluate, you can hence make the appropriate decisions, make the needed changes, so then you can administer another more optimized, a more improved health education programs. This diagram here shows you the same as I said, the responsibilities of health educators. They have divided them into 7 areas of responsibilities. And I said, as you can see on the left, communicate and advocate for health and health education. This is a very vital one that needs to be risen more and more as we are all part of the healthcare system. Finally, the last section of our lecture includes the patient education benefits. We talked a lot about health education, about patient education. We put the goals, we put the objectives, but what will be the benefits? Will we benefit even at all or no? The overall benefits of patient education, these are including the healthcare systems, including effective use of resources, healthcare professional satisfaction, fewer appointments, fewer outpatient visits, shorter stays in the hospital, fewer hospital admissions. Because if I have empowered individuals, empowered patients who are taking the most positive, optimal health-related decisions toward their health, including the different aspects of their life, including diet, including medication, including health-related decisions, overall cessation of smoking, exercise, etc., etc. Hopefully, all they're doing will affect their health in a good way. If their health is good, if their health is not good, if their health is in the best optimal level, their need to visit the hospital will be minimized. The need for them to be admitted to the hospital will also be minimized. And therefore, the overall healthcare system will benefit. We will have saved a lot of resources, which will even affect the healthcare professionals' satisfaction of their services. As for the patient, these we can even add more and more benefits to the patient. Improve their health outcomes, understanding of conditions, increased use of cognitive coping strategies, less time off of work, greater independence, increased self-efficacy, increased self-management, life expectancy, hopefully focusing on the longevity of life, making their life that they live much better, healthier, happier, reduces complications, fewer sleep problems, fewer hospital admissions. As I said, a lot of these you can see are about empowering. For example, empower patients to take an active role. We can see that the concept of patient education is all related. The main number 1 goal, empower. Please, we have to focus on empowering patients, individuals, communities, make the right decisions, Thereby, all of these benefits that you can see will be achieved. And when they are achieved, a lot of good outcomes will come to the healthcare system, to the healthcare professionals, and we will achieve our number one goal, making our society a healthy society that individuals in make their decisions not because they are told, but because they are convinced, because they make them through voluntary decisions only. And that is our number one goal, a healthier community, healthier individuals. These are the references for the lecture. And thank you for your time. I hope you have benefited from the lecture. Please feel free to ask me any questions if you have regarding any topics I have presented to you. And I wished I could have had a lot of time so we can take more time through the theories and explanation, but hopefully in our next events. Any questions? I will give you 5 minutes. If you have any questions, please write them in the chat box, please. Again, if anyone has any question, please feel free to ask. We have a question from Hanan Al Jassim. Thank you for your question. Can we choose the theory according to socioeconomic level? Of course. Of course, this socioeconomic level is a vital factor in choosing the theory. When you choose a theory, please, all of us, when we choose the theory, we have to put in mind all the factors that I've said. The number one factor was according to individual determinants, including socioeconomic level, including demographic variables about the individual. So we don't choose some people might think, I will choose the theory based on what is much more easier for me. No, this is a wrong approach. Rather, I take the levels, just like Hanan said, socioeconomic level, demographic variable, even the gender, the background, the culture, all of this level, and then I apply the theory that is most appropriate. And there's also a theory called the social cognitive theory. So read upon the theories. If I will try to see if we can give you access to the lectures, so you can take the notes and make more readings about them. Any other questions? We have an extra 5 minutes. Hanan, thank you. Another question. Can we use more than one theory in the same case? Yes, you can. It is possible for you to use more than one theory. However, sometimes some of the case for an individual, sometimes to make a much more focused approach, you choose one. But what can happen? You might choose, for example, the health belief model, as I said. And then throughout working out with the patient, you find that you are not reaching. Maybe you find maybe that even though you studied and you decided upon the most appropriate, you found that it's not really helping you achieve your desired result. So then you change. So that's why it is important to make the appropriate assessment before the thorough assessment before choosing the theory. But can we apply? Yes, we can. Yes, you can. And sometimes it will give you a different outlook for the patient's case. Any other questions? We have 2 more minutes. I hope all of you benefited from the lecture. And if you have even any questions, feel free to visit us. We are here in the Dammam Medical Complex, Health Education Department. If you have any questions regarding the theories, regarding the concept, regarding all the fundamentals I have spoken about, feel free to visit us. And we have 1 more minute before the next lecturer will proceed. We have a question from Munira. Thank you, Munira. What's the most important in patient community concept? When you ask this question, you can see a lot patient community concept. If you are meaning the community level regarding the patient community, you have to start. When you talk about community, how is a community built? It is built from one individual plus another individual plus another, making groups, these groups making societies, and thereby making the overall community. So when we try to focus on the community, we always have to start from the beginning, making the baby steps, starting from the individual and building upon. I didn't fill the Google form. Will I get the CME hours? Hopefully you can يعني receive your answer from the academic affairs, inshallah. There's a number on the poster for the event. Contact them and hopefully they will answer you. Which is the best method to be used in chronic diseases cases? When you talk about method, it's different than when you talk about theories. Of course, the method, the tools, hopefully my colleague will discuss them with you in the next lecture. She will go to details about the patient education process. However, the methods that when we talk about tools, we have orally, we have also written handouts, we have printed materials, discussion, demonstration. Most important thing, I will leave with this note, is when I talked about the domains of learning, I said we have 3. We have cognitive knowledge, we have psychomotor skills, and we have affective regarding the attitude and the belief. The most important thing is that when we are talking about the psychomotor, the one about skills, teaching the patient something they will do with their hands, even if it's as simple as using inhaler, injecting a needle, make sure this method, you have to use demonstration. You don't just use oral verbal education. Okay, Hanan Jassim, Ms. Leila. Of course, some of you asked, where do we work? Our event today, the symposium, is by our department, the Health Education Department here in Dammam Medical Complex. Ms. Leila, can we have your email or LinkedIn? I will put my email for you for further questions. It's okay. I will give you my Gmail. If you have any further questions, feel free to contact me. Hopefully, everyone has a clear idea about the concept of health education, concept of patient education. And when we talk about theories, put in your mind, they will give you a guideline to the actions, to the programs that you will make. And when we talk about domains, They are talking about the everyday efforts you do with the patient. Domains meaning if I will teach them a knowledge, I will give them maybe orally, verbally, through printed material. But if I teach about psychomotor, it must be demonstration. And the demonstration must be interactive. It goes both ways. You demonstrate the skill, and then the patient must demonstrate it back to you. How can I know that they know exactly what to do when they go back home? Yes. And when we talk about effective and attitude, it's much more different. It needs sometimes one-on-one discussion with the patient, one-on-one focus, so we can actually feel what's wrong, what we need to affect. So health education, just put in mind, it needs that little extra effort that you give the patient your time, give them your mind, give them your heart, and through our experience, we have seen a lot of positive changes made with the patients, and it's all more than good. Sometimes it's much, right now, nothing makes us more happy than when we see a patient who was doing something bad, negative toward their health, making that positive change and achieving a better health status. Thank you, everyone. My time here is up. My time here is up, and I will introduce you, inshallah, to the next speaker right now. Thank you, everyone. Hopefully, everyone benefited. Assessing learning needs, assessing learning styles, assessing learning readiness to learn. This assessment includes finding and what the patient wants, what they want and need to learn, and what they are capable of learning, and what the best way to teach them. When we start assessing the learning needs, here we can in this step determine what the patient needs to learn. What does already know about his condition? Does he know how to control or manage his health status? Does he has misinformation you need to correct it for him? What is his goal, and what is his vision about himself? In this step, we can ask the patient some questions. What are the most concerned about? What are your goals for learning? What do you need to know to achieve your goals? What specific problems are you having? What do you know about your condition? And what you most interested in learning about? How will you manage your care at home? The second part, assessing learning style. Second part of assessment, of patient assessment, assessing learning style. In this step, we can determine what? We can determine the patient preferred learning style. What's that his literacy level of education, finding out whether the patient learn best by hearing or reading. These examples for question you can ask the patient to determine the learning style. What time of day do you learn best? Do you like to read, or what type of books or magazine do you enjoy to reading? What you prefer to read something? Would you prefer to read something first, or would you rather have me explain information to you? Do you learn something better if you read it, hear it, or do it hands on yourself? third part of assessment for assessment, assessing learning readiness to learn. This part is very important because sometimes when the patient, when you educate the patient and when you want to educate the patient, he has some obstacle, avoid them to receive education. For example, if the patient has some problem with the motivation, okay, it's not ready to learn. When the patient has no motive for education, that means the patient needs more effort to convince him, and sometimes we need to touch his need and focus on it to receive the patient. Another examples for the obstacles that maybe face the educators, the disability. If the patient has
أنا وين يمديني ما أحضر لي الأشياء ما يمديني أصلا ساعاتي صفر يبغى لي أديها والله يغلموني لأن 60 ساعة مؤتمرات لازم أحضر
في المدة
2
وكم كيف حضرتي؟
صفر من ولد تريم ما حضرت ولا حاجة.
Can you close please excuse me. Can you close the mic?
يجبرونا
The
بفلوس
microphone, please.
60 الوحدة كم ساعة بالعادة؟
يعني مثلا دي المحاضرة 8 ساعات.
Excuse me.
500.
واو.
أنا ما دفعت.
Excuse me. Can you close the microphone? Okay.
لا أنا أدفع بس اليوم لا لأن أنا أتكلم.
Assessing learning readiness to learn. Assessing learning readiness to learn. Okay, this is the third part of assessment, of patient assessment.
انت ركز قال لي وشو سجلهم كلهم اللي اعطيتهم كورس صح؟ اللي اي شيء علمتك اياه السنه سجل اللي اعطيتك
نفسه بوذا
تمرين عليه. قمت خليت سويت فيها مكان
إذا ما خلصنا الساعات
يخلونا نشتريهم. We can review some of obstacles that maybe face the educator during the education, during patient education. We're talking about motivation and disability. If the patient has some kind of disability, physical or mental disability, so in this time the education not given to patient, the education given to the family and caregiver. Another examples of obstacles, the patient condition. If the patient have received some kind of medication affect his memory or his attention, in this time the education given to the patient and with the family, with his family or caregiver also. Here some examples for question may ask the patient. How do you feel about making the change we have discussed? What change would you like to work on it now? Are there any problems that would prevent you from learning right now? By answering of this question, we can collect the clear idea about the needs for the patient, and this help us to improve the learning objectives. And this developing learning objectives is second step of patient education process. Clear what is the how we can develop learning objectives. Clear learning objective states what the learner will be able to do upon completion of a continuation patient education activity.
After initial assessment, the educator and patient will work together to develop learning objectives. Depend on your assessment finding or the assessment finding. Here, you can develop the learning objective? Start with the words who, does, what, how, and when. For example, the objectives: the patient will list 5 signs of hyperglycemia by time of discharge. We can use the words who give the education. You give education to whom? The patient. Does will list the 5 signs of hyperglycemia. What the content of your education session? 5 signs of hyperglycemia. How? Accurately or by stating out loud. When? By discharge. Third step, planning and implementing teaching. Planning, the next step in the process, is developing teaching plan by focusing on each of the elements that make up the plan. We can use what, when, and where, who, and how technique. Here, how to develop educational plan. Plan what to teach, the content. Plan when you will teach, the time. Plan where you will teach, environment. Plan how you will teach, educational tools. In your planning, when you develop a plan, we can use a different teaching method, depend on the patient condition or patient situation. Here, some examples for the teaching method: one-on-one sessions, small group discussion and support group, demonstration and return, demonstration, role-playing, games, or programmed instruction. Also, we can use in planning different materials: pamphlet and brochures, posters and flip chart, videos and closed circuit television, computer, transparency, and models. Fourth step in educational process, patient educational process, evaluation. Evaluation is the ongoing appraisal of the patient learning progress during and after teaching. The goal of evaluation is to find out if the patient has learned what you taught. Here, some way to you can use it to evaluate your learning or teaching. Observe, return, demonstration, to see whether the patient has learned the necessary psychomotor skills for a task. Ask the patient to restate instruction to see his or her understanding by his word. Ask the patient question to see whether there are areas of instruction that need reinforcing or reteaching. Give simple written tests or questionnaires before, during, and after teaching to measure cognitive learning. Also, we can talk with the patient and family and other healthcare team members to give their opinion on how well the patient is performing tasks he or she has been taught. The last step in the patient educational process, documentation of patient teaching. Documentation are the entry of teaching process step. Documentation of patient teaching can be done via flowchart, checklist, care plans, traditional progress note, or computerized documentation. What's the purpose of documentation? Documentation promotes communication about the patient progress and learning among all healthcare team members. Good documentation helps maintain continuity of care and avoid duplication of teaching. As evidence of the fulfillment of teaching requirements for regulatory and accreditation organizations such as CPAHI and JCI accreditation. Here, what to document: the patient learning needs, the patient preferred learning style and readiness to learn, the patient current knowledge and about his or her condition and healthcare management, learning objectives and goals as determined by both you and the patient, information and skills you have taught, teaching methods you have used, such as demonstration, brochures and videos, evaluation of what the patient has learned and how learning was observed to occur. And here the summary of patient education process: assessment, objectives, planning and implementation, evaluation and documentation. By this slide, my presentation is over. If you have any question, you can write it in the chat, please. We have 10 minutes for a question. This is my reference. Thank you for your attention. If you have any question, you can ask me and write it in the chat box, please.
Our outline today: what is communication skills? What requires communication skills? Why you need to develop strong communication skills? The top 10 communication skills. What's stopping you from communicating effectively? Good engaged listener, nonverbal signals. So, what is communication? Being able to communicate effectively is one of the most important life skills to learn. Communication is defined as transferring information to produce greater understanding. It is usually a two-way process. Communication is giving, receiving, or exchanging idea, data, information, signals, or messages through appropriate media, enabling individuals or groups to seek information, to give information, or to express emotions. It can be done vocally through a verbal exchanges, through written media like books, websites, and magazines, or visually using graphs, charts, and maps, or non-verbally body language, gestures, pitch of voice, and tone. All of these means of communication are essential soft skills that are vital for a successful career. And now, what require communication skills? Almost every occupation requires strong communication skills in one way or another. The job that you are applying for will determine which communication skill you will need and extent to which these will be used. Why you need to develop strong communication skills? Effective communication will quick in problem solving, strong decision making, more productivity, consistency in the workflow, strong business relation, better control, advanced professional image, better response from all stakeholders. The 10 top communication skills. We're going to speak today about them. We're going to speak about emotional intelligence. Emotional intelligence, you should manage your emotions, avoid stress, overcome challenges, and empathy with others. Cohesion and clarity is much more than saying the right thing. It's about communicating messages clearly and concisely. Lack of clarity and cohesion can result in poor discussion and confusion. Number 3, friendliness. Use friendly tone. Always try to personalize messages. For example, wishing the recipient a good weekend. Confidence. Demonstrating confidence will give customers faith in your abilities to deliver what they need. Be careful not to come across as aggressive. Empathy, respect, listening. Pay attention to what the other person is saying, as ask questions and clarify points. Open-mindedness. Try to enter into a communication without having an agenda. Strong communication requires an open mind and commitment to understanding other people's point of view. If you disagree with the people you are speaking to, try to reach a middle ground that benefits all parties. Tone of voice. The tone of your voice can set the whole mood of the conversation. If you start the discussion in an aggressive or unhelpful manner, the recipient will be more inclined to respond in a similar way. Asking a good question. What's stopping you from communicating effectively? Common barriers to effective communication includes stress and out of control emotion, lack of focus. For example, if you're checking your phone, planning what you're going to say next, or daydreaming. Inconsistent body language. If you say one thing, but your body language says something else, your listener will likely feel that you're being dishonest. For example, you can't say yes while shaking your head no. Negative body language, such as crossing your arms, avoiding eye contact, or tapping your feet. You don't have to agree with or even like what's being said. Good engaged listener. Being an engaged listener can help deepen existing relationships and help you navigate moments of conflicts or tension. And it may come naturally for you. There are some tips to become a good engaged listener. Try to focus fully on the speaker. Favor your right ear. Avoid interrupting or trying to redirect the conversation to your concerns. Show your interest in what's being said. Suspend judgment or blame while listening. Paraphrase what you heard and seek clarification. Try to set aside judgment. Provide feedback. Steer clear of smile or laughter when messages are serious. Eliminate fidgeting and shaking of limbs. Avoiding slouching, sit with your back straight up against the chair or lean slightly forward to convey engagement. Avoid looking at the clock, your phone, or displaying any other signs of disinterest. Maintain open arms. Folded arms can convey defensiveness. Smile to indicate that you're amused or pleased with the conversation. Finally, we should pay attention to nonverbal signals. Nonverbal signals is 65% of communication skills. The verbal signals are only 35%. So what's the nonverbal signals? We have facial expressions, body movement and postures, eye contact, gestures, touch, space, intensity, timing and place, and sound. Thank you for your listening. Is there any question?
This is the outline that we are going to go through it, starting from introduction to conclusion. We are going to go through it briefly. Community influence the health status of people. Before we understand the community health service, we need to understand health and the most common health issue that cause death in Saudi Arabia. Then we can discuss the health service provided by healthcare provider for patients. Health. According to WHO, they stated is not the absence for disease. It just only means a state of complete physically, mentally, and social well-being. Most common health issue that Saudi Arabia face, according to CDC 2018, ischemic heart disease, road injury, stroke, chronic disease, and lower respiratory infections. Factors play a big role, influence health. Biological factors, environment factors, lifestyle, health behaviors, healthcare system. Most health determines by factors other than healthcare, 40% social and economic condition, 30% behavior, 20% healthcare activities, 10% environment. What does the community health service mean? It's a service which provides to patients care in the community, including provision of medical, dental, nursing, and allied health professional care to promote, protect, and perceive the health of those in the community. Why we need to focus on community health? Working at the community level promotes health living, help prevent chronic disease, and brings the greatest health benefits to the greatest numbers of people in need. This is reported from the CDC. A scope of community health service, it required multidisciplinary approach with all efforts goal to reduce morbidity, mortality, and improve the quality of life. Strengthening self-care activities to promote health and prevent occurrence of disease. Improve the standards of living to protect the health against disease. There are three levels of preventions: primary prevention, secondary prevention, tertiary prevention. Primary prevention and intervention implemented before there is evidence of disease or injury. It's reduced risk. It's basically like exercise or eating healthy diets to prevent from getting any chronic disease. Secondary prevention and intervention implement after disease has begun, but before it's systematic. Early identification through the screening and treatment. Tertiary prevention and intervention implement after a disease or injury is established. The most important community health programs, there are a lot of community health programs that we can join it, like health volunteering in the communities, seminars, conference, lectures, and health prevention campaigns, specifically in schools, university, public, and private business institutions. There is no way to improve health and community health unless we understand the community that we live in. Understanding the community that we live will lead to improve the quality of life and decrease mortality and morbidity rates. Thank you. Is there any questions?
Okay. You are a health caregiver in a medical facility facing a critical condition of a 65-year-old man with hypertension, diabetes, myocardial infarction. Caregiver in a medical facility examining a stable 65-year-old man in a wellness clinic for his yearly checkup. The clinic visit goes well and the patient is scheduled for another yearly checkup. Okay, such scenarios shows the importance of making the healthy choice the easier choice. You don't want to put the patient's health at risk. You don't want to put his family at risk. You don't want to be in a challenging position. So these are our lecture objectives. You can skim through them. Health promotion has been a topic of interest to the WHO since 1998. A conference has been made in Ottawa, Canada, which considered as an important landmark in the health promotion. They defined the health promotion as the process of enabling people to increase and control over their health and improve it. Since then, several papers has been published, several studies has been published, and Norman et al. In 2015, they've mentioned very important points that any planned combination of educational, political, regulatory, and organization support for action and condition of living conducive to the health of individual groups and communities. This paper is important, showing that it is a multidisciplinary work. It's a team effort work. You cannot just say that you will promote the population health without the work of the community. Okay, I still receive messages about the voice. Can you hear me right now? الصوت واضح أو غير واضح؟ Okay, we're good? Okay. Okay. So another important definition of health promotion is about the raising health of status of individual and community. This pointed that we're not only targeting the individuals, we're counting also the communities. Okay. So health promotion actions, they required a multi-professional and multidisciplinary work. The action should be advocate, enabling, and mediated. I will explain these 3 actions in the following slides. The Ottawa Charter Strategies has been published in 1998, and since then it has been used and added on or developed on, and these are build a healthy public policy, create supportive environment for health, strengthen community action for health, develop personal skills, and reorienting health services. I will example on the following slides. For example, the good governance. The good governance mean that policies has been applied, rule, regulations, such as smoke-free area or buckling the seat belts, receiving any fees if you are not following certain rules. Health literacy, improving health literacy in the community, allowing them to have an active role in improving their own life. Another focus of health promotion is healthy setting, that you will allow the community, the individual to take partnership, and this will allow them to feel empowered and thus give them more motivation in participating in the health promotion. Social mobilization also, meaning that we're involved in the societies, make them more influenced and more aware of the health promotion. Okay, I just want to point that health promotion, it's not only a one approach process. The approach of health promotion can be different by the population status. For example, a healthy population will only need, okay, still having voice not clear. Okay, let me know when it's clear. Is it clear now? Interrupted voice. Okay, very good. So again, health promotion approach, it's different from healthy population than population with risk and population with symptoms. And finally, it is vastly different than population with the known disorders. For example, a healthy population will only need promotion of healthy lifestyle, preventing risk factors, preventing of disorders and health problems. Meanwhile, population with risk factors, they will need screening, they will need an action for a risk factor, they will need a built-in resilience, they need to maintain the healthy lifestyle, and so on goes and applies to the different population status, health status. So for the healthcare giver, how to apply health promotion? We need to induce, transmit, facilitate, and maintain good health behaviors. Provide suitable environments so people can maintain healthy behaviors. Encourage health promoting lifestyle among communities. And that means we should allow them to participate. Allow people to take part in finding their own decision. So any health promotion campaign, a slogan or a message, it has to be trustworthy. You need to be credible, and information need to be credible from credible resources. Also, we should find an interest from their people need. For example, let's say we have a couples who need a family planning idea or a plan. These interests come from within the community or within the population. Involvement. The third aspect of involvement is very important. You can let the community and be a part of the decision making, be a part of the process of health promotion. Third one, motivations. Some communities have fears, some communities have their own thoughts that need to be corrected. So we should keep them motivated, and we let them be involved in every step of the process of health promotion. The fourth point, that the slogan or the campaign work should be simple and comprehensive. So it will be well absorbed by the community and to the targeted population. Maintenance. You cannot just say, okay, we'll have health promotion in this specific date and it will end in X amount of time and then that's it. you should maintain what you've done. So the health promotion will also contain as a running aspect of the population. Feedback means that you're going back to the population who receive the benefits, the health promotion advantages, and see if they really absorb what you've given them, if they are an example of health promotion is helping smoker quit and promoting smoke-free public spaces, increase access to healthy food and physical activities, promoting healthy lifestyle, promoting chronic disease self-management program, promoting women's reproductive health, promoting clinical the urban counterparts. This because they have a limited access to health promotion and health facilities and other preventive programs. Other preventive programs, it's not only for adults. This obstacle does not mean we cannot overcome it. We need to reach the status of have health equity, and the privilege of receiving health promotion should be covered by all and received by all. So how to improve health promotion from my perspective? And from the papers I've read on is implementing policies that mean we need to impact the policies that impact the health, such as regulation, community participation, environmental sustainability. The next point is partnership with all level of organization, whether they are governmental, non-governmental, health sector, businesses, and community itself. So the changes will be more successful. Lastly, social media and health promotion. This time, frankly, is the time of social media. This will allow to adapt a new promotion program, facilitate spreading the messages, allow the community to participate. And we should take full advantage of the social media to help us reach the point of health promotion and social and health equity to all social levels. And it is for me. And these are my references for your use if you can. And thank you. Let me know if you have any questions in the chat area.
Is my voice clear for everyone? Okay, I think it is clear. So I will start today my lecture. Good morning, everyone. Today I'm going to talk about health education and public health. The reason that I choose this topic is because the importance of these two sciences, and because they overlap with each other in different and in many areas. And public health specialists, they work as health educators, and also the health educators, they work as and with public health specialists. So first of all, we will go through our objectives. So our objectives for today, first of all, is to discuss public health definition. So we will define what is public health in general, and we will go overview the public health duties. We will also discuss health education definition. I'm sure that my colleagues earlier this morning, they define and they elaborate more about health education, but we will just go overview it. And we will also overview the health education duties. We'll discuss public health educators and their responsibilities, and we will know their focus, the public health educators' focus. Okay, so first of all, what is public health? According to WHO, it is one of the sciences, same as other sciences, that mainly deal with promoting health, preventing disease, and prolonging life. These things targeted the population, the communities, the societies, individuals. So it is a diverse field focused, they mainly focus on improving the lives of individuals, and they focus mainly on the community because if the community health is good, the population and the individual health will be excellent. So anything that affects a community health become a public health issue. Anything that targeted their health, affect their health, improving community health become a public health issue. So in this picture, this is only a summary of public health professionals, what they do. So they aim and target at to improve health. So they do health promotion. And my colleague, Dr. Zahra, she already talked in her presentation about health promotion. And public health professionals, they do surveillance, they do monitoring, analysis, they deal with outbreaks, they targeted and design programs aiming to disease prevention. They also deal with environmental health. They do also research. The picture was a summary, and in this slide, I will elaborate more about public health professionals, what they really do. So first of all, public health professionals, they monitor the health trends. So what is health trend? Health trend is the inclination to proceed in a certain direction used to describe a prognosis or course of symptoms. And I will give you examples, and which include, okay, this may include aging of a population. They study the trend of aging of population. Also, they study the changes in healthcare. So, for example, the healthcare before targeted treating the disease, now they are focusing mainly on preventing the disease. Also, they also include the health trends, changing needs in a public health workforce, and also changes in healthcare delivery system, how they deliver the healthcare system. For example, previously, the population, they go to health centers directly. Now we have not only health centers, hospitals, and also it make it easier for delivery of healthcare, that we have now the application Maw'ed and etc. Okay, and other thing that public health professionals do, they establish policies to help improve the communities. And actually how they develop policies, when we have a problem or health problem, these professionals, they want to put a solution. So they put a policy and they focus on implementing the policy, this health policy. Okay, they ensure that established protocols are known and followed. What mean by established protocols? They mean guidelines, treatment protocols, aiming to for promoting health. Okay, they develop health promotion and health education programs, they implement it, they conduct researches, evaluate outbreaks. So what is health education? Health education, according to WHO, it's a process of providing information and advice. Mainly, they go not to the communities only, they also targeted the individuals, same as public health professionals. These advice and information, they are related to healthy lifestyles. They encourage this population or community, they encourage them to develop knowledge, attitude, and the skills aiming to behavior change of their individual and communities. I will not go more or very deep in this in health education because I know my colleagues already talk about it. So this picture show us what health educators do and what is their process. So they have their essential health concept, they know the concept, they analyze it, okay? They access valid health information because they go through, trusted websites and good resources. Okay, they do communication, they communicate with the communities, the individuals. Okay, they make decision making, they set a goal, okay, and they practice health enhancing behaviors through the programs, through brochures, through other methods, targeting the health promotion and health to increase the health. Okay. So in this slide also more about what health educators do, and I already explained it, that these health educators help the people understand the health information, they help them how to apply it, and they make their choices more healthy and change the lifestyle of the population. Okay. So health educators serves as important part of public health team, and public health professionals and health educators, they work together to benefit the communities, aiming the same thing to benefit communities and improve the life and the health of communities. So we may call them public health educators. So these public health educators, they focused on helping groups of people. They help whether a small community or big population, individual by themselves, okay? And they work on developing, implementing educational campaigns, programs, promoting the health environment, changing the behavior, changing to healthy lifestyles. What are the public health educators' responsibilities? Public health educator responsibilities somehow joining between the public health duties and health education duties. So they assess individual and community needs. They go to individuals or communities and they assess their needs. For example, one community, for example, they may need more chronic disease clinics because they have a chronic disease patient, more chronic disease patients. One community, for example, or retired people, so they don't need, for example, playgrounds, they don't need campaigns for school or for kids' health, okay? They manage also the health education programs. They write the health education programs, they evaluate them, they manage them, they ensure the people and the communities, they apply these health education programs. They write health proposals. For example, if you have an initiative, a new initiative, and you want to apply it, they write the health proposal for this initiative. Okay, they develop social marketing and media campaigns through different methods. They may use the social networks or go immediately to people to do the campaign, brochures, video recording, okay? They conduct research and they write articles and publish it in journals. They do a lot of things. Okay, so what are the focuses of public health educators? Okay, they focus on any public health issue. And in this picture, they just summarize the different topics they focus on. The public health educators, they may focus on smoking cessation, and they may focus on nutrition, weight management, sexually transmitted disease, chronic illnesses such as diabetes, asthma, heart disease, hypertension, and so on. So they focus mainly on disease prevention, whether it is infectious, communicable, non-communicable. They focuses on mental health, okay, women's health, environmental health, human growth and development, safety, health, and substance abuse. For example, smoking. Okay, public health aspects in relation to health education. The health education and the disease prevention is an important aspect of public health, and it can be transformed by informatics and by graphs, aiming and establishing healthy lifestyles. These just few methods, or we can call it new methods that can be used in health education and public health. They can use interactive guidelines, they can use apps and, through mobiles, the preventive care reminders, okay, linked to electronic medical records in the future, inshallah. Computerized health risk assessment, so we can do health risk assessment, which is typed and computerized, send messages, and that's it. Any question for me? I will be happy to answer them. Thank you. These are my resources. And thank you all for listening. Thank you for giving me this opportunity.
Forward. Thanks for this opportunity to share some experience with you. My colleagues, Ms. Layla and Ms. Fatima, actually spoke so many things about the topics I'm willing to share. So it will be very quick and easy, and hopefully a comprehensive lecture. So let's start without further ado. I'm speaking from a pharmacist point of view, and hopefully pharmacists and health educators also will benefit from some points. So we're not going through definitions, but I'm gonna just emphasize on something that we do as pharmacists. The definition of pharmacy education or medication education, it's a bidirectional method that means two-way, a receiver and a sender. The aim of it that the healthcare provider, the pharmacist in this case, will increase the knowledge of the patient and awareness about his medication and drug regimen, so that his adherence might be enhanced and influenced. What are our goals in educating the patients? Most of the things that we are considering in this situation is that the patient is not aware of what effects of his well-being is. As we see in some slides in the second lecture, that the patient thinks he's genetically not affected. No one of his family has a hypertension or lung disease. So most likely this is not true, and he will overcome it. And sometimes thinks that the drugs will do him harm more than benefit. So we must explain this thing to him and try to elaborate on that area. We also, as they said in the morning, have to adapt him or give him a coping strategies to deal with medication side effects and drug and food interactions. We must motivate him to take medicine for improvement of his or her health status. Sometimes the patient is not well educated and or medical or medication illiteracy. So in this area, we need to increase his knowledge so that he can make an aware and good choice about his medication regimen, and he can participate in it. So I'm going to talk a little bit how to start your counseling techniques more than knowledge, because it was covered in the morning. So most of the time, the patient or the healthcare provider miss something else in speaking with the patient. They do not introduce themselves to the patient, so there is no familiarity between them. Sometimes they do not review their medical records, so he will be, let's say, less knowledgeable, and the patient might surprise him with some information he did not know. So it's a good choice that you read the medical record before interviewing the patient or during the talk with the patients. One thing that's important also, that the patient is multifactorial. That means he will go to so many healthcare staffs and he cannot deal with you. How come? He will go to the physician, he will tell him something. He will go to the nurse, she will tell him something. He will go to the lab and he will hear something. So you must hear what everybody had said to him so that you can deal with it. You cannot contradict your parties, even if he was wrong, especially the physician. You do not want to destruct the trust between the patient and his physician or his healthcare provider. So you must be cautious in that way. Explain to the patient, why are you seeing him? What's your rule in that area? Be honest and be accurate with him. And you should give him some things to know about the medications. And also you must think about his beliefs, as they said. That's not just beliefs of the medication, his religious beliefs. Sometimes, and we'll see it later on in another slide, being a Muslim might affect your choices of medication. Being a Western or Eastern or a middle region inhibitor will also make some verbs or some accents even or tones of speaking not polite or not exact. So you must know this and try as much as possible to consider in counseling the patient. You have to make your an agenda, because some patients also have an agenda. So you must prepare yourself and know that sometimes the patient will come to you when he was not in need for medication, but in one way or another he got it. So you must know how to deal with it and convince him not to go in that direction. Sometimes the patient is not really wanting to get well, and it might be a confusing thing, right? If he's not willing to get well, why did he come to you? Why did he visit the hospital? Well, there is so many factors, but I'm going to give you an example that you can think of. Let's imagine that you're working in distance area and one of your relatives, wife or son, is sick, and you come only 1 or 2 times per week or per month. But when she was sick or he was sick, you had a sick leave or a vacation and came and stayed with him. When that patient sees that you're around him more than required, he might be happy. So being happy with being ill might make him not wanting to get well. Hope the idea was there and missing. So you must to see out this area and try to discover if the patient is really wanting to get well or not. Sometimes social and economic factors can affect his healthcare decision. And this is something I see a lot in my clinic. The patient is wanting to get well, but he doesn't have the money to get to you. He doesn't have the money to come each month so that he can take the medication from the pharmacy. Now we have the postal service, but even so, he might be not having money to have an internet, or he might not even knowing how to use the application, Google Forms or others. So you have to look for these things too, because they will affect his compliance to the medication. In the counseling, you will discuss with the patient so many things. So it's helpful that you make yourself a list, a checklist, and make sure that you give the patient everything that he needs to start taking his medication and deal with the side effects that could happen. So first of all, you have to explain to the patient what is that drug for, how it's going to help him, what potential side effects could happen, how he can prevent or manage these side effects, if there is special precautions for, let's say, conceiving, pregnancy or spermatogenesis, lactation, if he's going to develop something that affect his current disease or another things that might be he's taking from another hospital, the OTC drugs. And during the process, you have to scope for another things. The patient is willing to talk, but you have to draw him out of his hide. And one important thing is that I see it a lot. Most of us, they do not speak from a reference. They speak from their minds. They memorize things and they speak it out. And sometimes your memory can trick you. So it's helpful to open your reference and make it by yourself. When you hesitate to tell information, pause for a minute and look at the reference again. And lastly, you have to use a very simple language. And we'll see how 3 times a day sometimes means more than 3 times a day. We'll see in the barriers that sometimes we need a counseling aids, written or audio or video for some special kind of persons or difficult to comprehend persons. Try to make your facts in logical order. As we saw in the morning, there is so many factors and so many methods to use. So each patient will be dealt with in a different matter. If I'm speaking too much fast or you have questions, do not hesitate to ask me, even orally or through Q&A. The final step, always in the conclusion. You will give the patient a summary of what you have said, and then we'll ask the patient to tell you in his words what he understood. And it's also a good thing to do. If the counseling session is long, try to make pauses. For example, explain to the patient what the drug name is, what trade names might be available. Then ask him what did he learn. Then move on to how to take the medication. Then ask him again. How are you going to take the medication? Then move to side effects and misdoses and these things, and ask him again. And finally, ask him again, what did he comprehend? They talk in the morning also about the interactive communication skills. And I want to emphasize on the word interactive. Communication skill is very important, but if it's not an interactive, then you will lose your patient and he will not get anything. We are not lecturing, we are dialoguing. We are making a conversation with the patient. And a conversation is something between two persons. Not one is hearing and the other is speaking. Both of them will speak and hear. So do not make previous judgment. Let the patient speak out when he wants. Even if you know what he's going to say, just wait for a little bit. These are the 5 key elements of interactive communication skills. What are they? Always use open-ended questions because it will give the patient an area to speak out. And he can tell you what he needs. Okay? They said in the morning, and I'm emphasizing again, your behavioral cues, non-verbal. Be aware of it. If you leaned on one side, that means you're not interested, or you want just this session to finish up. If you lean forward towards the patient, that means you are caring. So be aware of it. Active listening, and we'll hear later on what active listening is and how it sounds. Reflective responses, that means he will say something and you will say it back to him. So that means he will understand that you was listening to him. And finally, verify the understanding. If you heard something and you was not sure about it, you say it again so that the patient will know and can comprehend what you said and say that it's true or not. Okay. So use open-ended questions most of the time, but you can use non-open questions. Use more often, as they said, when, how, why, and what, and where, and who. And less often use do or are. Because the close-ended questions, most of the time, will restrict the patient towards a special area. He will not be able to speak out everything that he needs. These are some examples. And instead of saying, do you know what your patient, your medications is for? Tell him, what did the doctor tell you about your medication? So that he can speak out more and more. Back again to the nonverbal cues. As we said, try to be friendly, smiley. Your voice is clear and as much as language easy and can be tailored to the patient needs. With time, you have to work on it and see what's the patient reaction to your action is and try to move on. Apologize if you make a mistake or you felt that the patient was offended for any reason. Most of the time, the patient will look to your body language more than he will hear your words. So try to make them both aligned in the same direction, so that if he did not hear you very well, as they said, 35% of verbal and 65% of body language. If he did not hear what you said or did not understand it, he will read your body language and knows that you are keen for him. Try to make eye contact. Try to be professional, because sometimes your appearance might distract the patient. Be relaxed, comfortable, attentive, and make a proper distance between you and the patient. Change your voice, raise it a little bit, lower it down when something is not that much important. Emphasize on things, but be aware of using high-pitched voices. So let's go to active listening. How do you know that you are doing an active listening? Or what can distract you from active listening? Sometimes, and this happens a lot with physicians, they are busy with filling the forms, writing the notes on the system. So he might be speaking with the patient while he's writing on the system. So that way the patient will feel that you're not that much interested, or you're not giving him the attention that he needs. So be patient and try to make time. Even one moment that you look at the patient, he will feel that you are busy, but you are looking at him. Try to do one thing at a time as possible. When you are speaking with the patient, do not write anything. When you write something, do not speak with the patient. Okay, this is a useful tool also, we can use it. Paraphrasing, clarifying, summarizing, and feedback. So what paraphrasing does it mean? It means that I will say the same thing in another words. For example, we always say that take your tablets 3 times daily. But what does 3 times daily mean to the patient? You'll be surprised that some patients will think 3 times daily, that means 3 tablets 1 time. And some of them will think that it's only 3 tablets for 1 day. So you have to say it again. 1 tablet in 3 different times. If he did not understand, say it again. 1 tablet in the morning, 1 tablet in the afternoon, and 1 tablet at night. If he did not understand, say 1 with the breakfast, 1 with lunch, 1 with dinner. And try to find the thing that the patient will comprehend. Try to clarify the things to the patient. When you think that he's, let's say, not with you, or you think that he's surprised from what you say, that means either he did not understand or he was not expecting. So try to clarify it again for him. And summarize at the end, because sometimes you will take 15 or 20 minutes with the patient, so he will lose some information. So try to summarize and give him a take-home message. These are some questions that you can use that shows that you're an active listener. I'm not going to say them because I think that we are running out of time and then have more slides to speak out. This is an example on summarizing. And active feedback is, I see, no, I don't feel that way. So that's what you found out. Reflective responses. The major advantage of these responses is that they make the patient, or in that case, the healthcare provider, empathic without having to agree with the patient on his saying. For example, the patient is afraid of taking insulin because he is afraid of needle hurts. So you can say to him simply, I can imagine why you are not wanting to start insulin. It's painful to be booked every day, but you know it's very crucial for your health. So you need to take it. So you showed empathy, but at the same time, you did not agree of him not taking the medication. This is an example. I'm just not sure about this medicine. So think as a pharmacist or healthcare provider what your response might be and compare it to our suggested response. It seems that you are concerned about your prescriptions. So you convey the message with another words, and that means you listen to the patient and his complaints. This is another example. We'll skip it. These some responses that you show that you are empathic You can use more, of course. Finally, the verification of understanding. You will tell the patients to speak out again what he heard from you in simple language. And you will verify that he understood the message you are trying to convey for him. This is important. The question that you ask the patient is most crucial because you don't want to make the patient feel that he's being quizzed or tested. So you have to choose your words wisely. An example of it. Now, tell me how you are going to take your medication. And instead of saying, okay, I'm going to ask you now some questions to make sure that you understood what have I said. What have I said? That way, he will think that he's offended. He might be angry. He might think that you think he's stupid. So just make the problem is your problem. I want just to make sure that you understood everything. So can you tell me how to take your medication? It's better that way. These are examples on prime questions or opening questions that you can start with the patient with. I will take only one example for the sake of time. What did the doctor tell you about your medication? What a problem or symptoms is supposed to help? What is supposed to do? What your medication is supposed to do? If he's on a refill prescription or you're probing for adherence, these are 3 types of questions you can ask. So, what were you taking this medication for? Have you been taking it properly? Did you have any problem with your medication? This is some example on verifying the patient's understanding his knowledge. Let's talk now about some difficulties you will encounter during the counseling and how can you overcome these things. Most of them will be encountered by interactive communication skills, of course. So the language barrier, and here it's different. He might be not an Arabic speaker. He might be doesn't even have second language like English. He might be voice impaired. He cannot speak. So some useful things that you can use is pictures, or you can call an interpreter or translator to help you in that matter. And we have in the hospital so many ones. Counseling a third party. And this is very difficult because sometimes the message will be different when it's transferred by a third party. So try to give him a written supplements or video or connection, or give him a call and let the patient call you back. If he's here impaired, use printed material, move to a quieter space, speak more loudly but do not shout, and you must use a final verification technique. You will ask the patient, what did he understood? If he is vision impaired, use interactive dialogue, a final verification again, and provide large print material if he is not blind. In mental disorder, the most thing is that you will counsel this caregiver or third party that will take the care of the patient himself, and you also will give him a written supplements. These are also more examples that will deal with the patient with. These some barriers that will come from the patient himself. He might be overly talkative, so you have to take control and stop him. If he is interrupting or wanting to lengthen the conversation, try to stop him again and focus on the matter that you are discussing with him. If he's interrupting your routine or with another patient, just tell him politely that I can meet with you before lunch for 5 minutes. or I will finish this patient and I will come to you. If the patient is discussing issues that cannot be resolved, politely and as gently as possible, try to tell him, well, we disagree on that matter, but keep taking this medication and till we find another solution. If there is difficulties in reflective listening, try these techniques. For example, the patient is saying, I don't want to start using insulin, and instead of saying, no, you must do it, you will be sick, say this word. You don't believe starting insulin will start working for you right now. So you just took his words in another way and you convey your message to him or amplify your reflection. I don't know why my wife is pushing me to use insulin. Huh. So your wife is concerned for no reason. That means you are surprised that he doesn't see why his wife is concerned about him. And you have two-side reflection. I don't want me to start insulin, but I'm not going to do that. You can see that there are some real problems with your glucose control, right? But you're not willing to think about starting insulin. So you gave him the problem and you gave him the solution. So you gave him a question to ask himself about. Is he wanting to get well or not? Does he have a problem or not? Agreement with a twist. I don't know why my wife wants me to take insulin. She wouldn't like it much if she had to be poked herself so many times. So you will reflect as saying, that's right. I don't think injection would be much fun either, but it's important to have your blood sugar control. So you agreed with his problem, but you took him back again to the real problem that he should focus on. You can reframe his belief into another belief. He's saying, my wife is bringing up insulin and nagging me about food and my blood sugars. Your response should be something like, I can see how you might think your wife is nagging you about your insulin, but she must really care about you to do that. So you will shift his anger to be a compassionate. Again, make the patient think that using insulin or not is his choice. So if he said he's not ready to start insulin, tell him, well, it's your decision to do, but I'm here to help you when you are ready. I can offer several resources and tips that can help you to be convinced about it. Do not insist on taking it because he will resist more. Just let him think that we are just helping him to make the right choice. Or shift his focus to another way. If he thinks that he's not ill because he doesn't have diabetes problems, tell him, well, I'm happy that you're feeling good, and we want to keep you feeling that way for much, much longer. These are some things that we don't want you to do during the counseling. Do not think that you will have the perfect patient. Patients might take medications in different ways than is written or than you know. They may take medications that are ineffective. So it's your duty to discover if current therapies are helping him and refer him to a specialist. For example, a pharmacist, a primary physician, to discuss about the drug regimen. The patient should be concluded accordingly. Do not expect to know everything. Do not be afraid to make mistakes. And one thing that you must do as an educator, do not second guess the prescriber in front of the patient. What does we mean by that? Sometimes the physician might write the drug for an indication that is not written and not approved, or he might use it for its side effects that will help the patient. So do not tell the patient, I'm not sure why he's giving you. We usually is not using this drug that way. There is another drug that can help you. But I think that we need to speak with your doctor about it. Simply speak with the doctor, make the appropriate adjustment if possible. If the physician insisted on his choice, politely tell the patient what to expect and how to deal without second guessing the prescriber. And one important message that you have to do not leave the patient without hope. Do not tell him, well, we gave you everything possible to treat your disease and we can't give you anything more. That will kill the patient more than the disease will kill him. So please do not do it, even if it's true. Tell him, well, this medication will take time. There is another regimen that we can do. We can shift you on other things. Try to give him anything else. These some questions that you will ask your patients to know that if he's adhered or not. Pharmacist, you can contact me if you want this form. Other healthcare providers, if it's helpful also, I can provide it for you. I think we finished. I hope that I gave you the information that you need and I added some words to your information. This is my contact information if you want the lecture to be sent to you out, or if you want questions to be answered, I'm more than happy to do it so. Hope that you have a nice day and that you got a fruitful meeting with us, and hope I convey my message very well. And if any questions there, I'm happy to answer it. Thank you very much.
About hypertension, nutrition, and lifestyle changes. Okay. We will identify the importance of lifestyle factor, and we will understand the learning style of different patients. Okay, we're going to start with a question. Is high blood pressure, like wrinkles or gray hair, just a consequence of aging? You can write on the comment section if you agree or disagree with this statement. Okay. I'm going to comment on this statement. In areas like rural China, where average blood pressure remained around the ideal of 110/70 their entire lives. Their diets may have played a factor, given that the only population in the Western world that enjoy such low average pressure because they eat directly from their farms. So high blood pressure might be a choice. Okay. Blood pressure is the #1 risk factor for death in the world. Increased blood pressure may put a strain on the heart and damage the sensitive blood vessels in the eyes and kidneys. So this high blood pressure leads to a lot of more diseases. So this is why we will talk about it today. Okay, it leads to heart failure, kidney failure, stroke. Okay. We should know the normal reading is less than 120, and if it gets elevated, other complication might occur. Okay. There are uncontrollable variables that affects getting hypertension, such as being older, being black, the race, and some families, it runs on the family. And we have controllable variables, such as having a low physical activity lifestyle, being sedentary, having a higher sodium and lower potassium diet, the weight, being obese or overweight, having a stressful lifestyle, getting a poor sleep at night, less than 8 hours, and smoking. On our dietary department, we recommend the DASH diet. It's a shortcut for the term dietary approach to stop hypertension. It's rich in vegetables, fruits, whole grains, low-fat dairy products, olive oil and olives, and limited in sodium, salt, sugar, refined grains, red meats, and high-fat dairy products. Okay, when we say limited sodium intake, we mean reduce it to 2,500 milligram, and I'm going to talk about it and how to explain it to the patient on the next slide. Okay. So when we say 2,400 milligram, I mean 1 teaspoon for the whole day. This is the normal patient, okay? And if hypertensive, studies have shown that reducing sodium intake to 1,500 milligram, much better, okay? So if we divide it per meal, it will be from 400 to 600 milligram per meal, okay? So less than a half teaspoon. But unfortunately, many patients take around 5,000 milligram per day. It's triple the recommended amount. Okay, so when we educate the hypertensive patient about reducing the sodium, we should teach them about hidden sources of sodium and how to read the label. For example, a bag of chips, 30-gram bag of chips, very small. The sodium content, as shown on the red circle, it's 270 milligram, which is almost like a meal. Okay, so we recommend them to focus on the hidden source of salt and not just the table salt. So you can find salt on chips, fast food, instant noodles. Okay. So why, when we talk about hypertension, we focus on sodium reduction? I found you good studies about this subject. In this study, people with high blood pressure, they put them on a sodium-restricted diet, and their blood pressure drops. Okay. And with the same diet, they gave them pills that contain salt, and their blood pressure goes back up again. And the more sodium they secretly gave them, the higher their blood pressure climbs. Okay, I will link all the studies at the end of the slides. Okay, so this is the diagram that shows the study. Okay. So the first line of treatment is lifestyle modification. And another study that shows how the dietary salt influence postprandial plasma sodium concentration and systolic blood pressure. It shows the effect of even having one salty meal for the hypertensive patient. They took a group of patients and they give them a soup that contains 6 grams of sodium, and they monitor their blood pressure. It kept rising, and it came back to the baseline after 4 hours. So even one salty meal can affect the blood pressure on the hypertensive patients. Okay. Why does sodium intake raise the blood pressure? It's the body's way to push salt out of the system. Another study shows if you combine sodium reduction and the DASH diet, reduced the blood pressure readings improved more. Okay, so for the systolic blood pressure, it dropped by 7 points, and for the diastolic blood pressure, it dropped by 4.8 points. These reductions occurred with no change to body weight. So I'm talking about modification of diet and salt reduction without the other factors like reducing body weight and exercise. So it's very important to focus on the diet for the pre-hypertensive and hypertensive patients. Okay, so when the patient comes to my clinic, I recommend the patient to get a divided plate, such as the picture, and to fill half of it with vegetables and quarter with protein, like fish or fat-free meat, and the other quarter with complicated starches, such as rice or potatoes. Changes of dietary lifestyle. In the 90s, 80s, 75% of calories came from meals and only 25% came from snacks. They used to have 3 main meals and only little snacks. But nowadays, people, for example, they eat breakfast at work and then keep snacking all day until they get home, maybe at 5 or 6 o'clock. And during this time, they drink coffee, chips, chocolate, sodas. So the problem is that people treat snacks as a treat. So instead of having a light snack such as carrot or grapes, the patient tell me, I just eat little snack, and he mean chocolate, okay? So we should inform the patient that a snack is smaller than a meal and it's nourishing. So encourage your patient to eat more at mealtime and eat less between meals as a snack. Okay, lifestyle steps to reduce hypertension: moving more daily and being more active, get a good night's sleep for 8 hours, lose excess weight, relax and reduce stress, drink more water and walk daily. When I recommend my patients to do exercise, aerobic or cardiac exercise that raise the heart rate is very good, and weight training. I don't mean like go to the gym. The patient may get a resistant band, just as shown in the picture. It works effectively on strengthening the muscles and building more connective muscle fibers to keep the body strong. So walking is wonderful, but not for everyone. If the patient can do more, it's better. And the resistant band is affordable and they can find it on any gym supplies. For the overweight patient, losing 5 kilos of body weight can reduce the risk of developing hypertension and diabetes by up to 65%. If hypertensive, this may be as effective as some prescription drug. Any kind of weight loss can lower blood pressure, even minor weight loss. We're talking about 3 to 5 kilos. It may really help the patient, even if they remain significantly overweight. I have this wonderful study about adding more fruits and vegetables and how it affects blood pressure. They took a group of patients, hypertensive. They didn't change anything on their diet. They just added more fruits and vegetables portions, and the blood pressure dropped by 7 points by only adding more fruits and vegetables, because it contains fibers, potassium, very essential nutrients. Okay, and this study shows the regular aerobic exercise and how it affects the hypertension. They took a group of patients, they didn't change their diet or lifestyle, they only included regular aerobic exercise for 13 weeks, and the mean fall of resting post-exercise blood pressure, it was, the drop was almost 9 points. Okay, so this will show you the effect of regular exercise on the patient. Studies showed that blood pressure medication will make the hypertension drop by 15 points almost. I just want you to compare and to add them all together to get the best result. Studies about cutting salt for hypertensive patients, the mean fall of a blood pressure was almost 16 points. So this is a very good drop. Okay. The effect of adding hibiscus tea. Hibiscus does appear to boost nitric oxide production, which could help our arteries relax and dilate better. So when they added hibiscus tea to the diet of the hypertensive patient, it shows a really good effect and it helps on relaxation. This is a study about beetroot supplementation, Shamandar. They took two groups. The first group, they gave them 1 shot of beet juice a day, and the other group, they gave them berry juice. And significant drop of blood pressure was seen on the beetroot group. Okay, but after stopping the experiment, their blood pressure raised back up again. So we have to eat our vegetables and keep eating our vegetables to get the best results. Nitrate-rich vegetables may prove to be both cost-effective, affordable, and favorable for a public health approach to hypertension. Okay, such as beetroot, spinach. Okay, another great study shows the effects of adding flaxseed, ground flaxseed, to the diet of hypertensive patients. They took a group of patients, they gave them 1/4 cup of flaxseed, and they monitored them, and hypertension was dropped. Yeah, studies, I will link it to you later. In conclusion, give your patient the assurance that they can manage their condition and let them help you find the solution for their condition. Reflect back what they say so they know you are listening. So you have to focus with the patient. Give a written instructions because most of the patients, they will forget half of what you say on the clinic. Be an example for your patient. It's okay to tell the patient that you brought your lunch with you for work, you can show them. Be an example. So at the end, thank you very much for the organizers and the hosts and all the participants. And thank you for giving me this opportunity. And if you have any question, you can ask.